GI bleed managed by non-endoscopic method, and one case of Chittamrit poisoning. That was 4 cases we presented on June 26th. So this is our second clinic, and all this work is done by this group of people, six of us. Dr. Vivek is sick today, so he is not available for presentation today. He has got conjunctivitis, that's why. He has not come to present this case. So today we will be presenting 4 interesting cases. One is a patient with achalasia cardia managed by POEM. Second is a patient with neuroendocrine. Third is a patient with acute cholecystitis managed by US-guided cholecystogastrostomy. And the fourth is patient with acute necrotizing pancreatitis managed by US-guided necrosectomy. So coming to first case, so it's a 35-year-old female. Actually, she was working as a nurse in Ireland, and she came for vacation. She presented with dysphagia and regurgitation for 6 months, and nocturnal symptoms, cough and features of aspiration pneumonia for 3 months, and she had a weight loss of around 6 kg over 6 months, and she had no other comorbid conditions. So we did endoscopy. It was suggestive of classical achalasia cardia. There was resistance at the lower end of esophagus, and there was some pooling of saliva also. So this is classical of achalasia cardia. Symptoms also classical of achalasia cardia, and we did a barium swallow. This is called timed barium swallow. You do a barium swallow and take pictures at 0, 1, and at the end of 5 minutes, and you can measure the height of barium column also. This is called timed barium swallow. So again, this was suggestive of achalasia cardia, and we did high resolution manometry. Again, this is suggestive of type 2 achalasia cardia. So you can see the IRP, that is integration relaxation pressure of LES, or simply the pressure of LES is around 22, very high. And there is you can see there is no peristalsis in this manometry topography. So, and there is pan-esophageal pressurization. That means there is low amplitude simultaneous contraction. That means the smooth muscles are contracting it simultaneously, but very low amplitude. So this is suggestive of type 2 achalasia cardia. So after initial workup, we took the patient for POEM, that is peroral endoscopic myotomy. So this is performed under general anesthesia, and we will use only carbon dioxide. So you should never use air for insufflation. So first and foremost, you should make sure that esophagus is clean. It should be crystal clean. There should not be any food residue. And you have to make sure that there is no candida also. So, and usually we start doing incision at around 10 centimeter above LES. So if LES at around 35 centimeter, we'll start from 25 centimeter. So first is to raise a mucosal bleb. So we are injecting around 25 ml of saline, and then we are doing a mucosal entry. Usually this cut will be around 1.5 to 2 centimeters. So actually this is the most important step, that entry, mucosal entry. And we have to undermine the edges also. So anytime you can have bleed also from this edges. So the second is making a tunnel. So what we are doing is with the use of triangular tip knife, we are making a tunnel of around 12 centimeter size. So we'll be injecting saline and we'll be dissecting also. This is actually what we are making a submucosal tunnel. You can see this is muscle. This part is muscle. This part is mucosa. So we are creating a tunnel of around 10 centimeter. That means around 10 centimeter above LES and 2 centimeter below G junction. So around 12 centimeter of submucosal tunnel. And while doing this tunneling, we can encounter a lot of submucosal blood vessels. So you have to catch those vessels and cauterize also. So whenever we are approaching G junction, there will be tightness. So actually that's a crucial point. But slowly we can dissect all those muscle fibers, submucosal fibers, and you can see very good tunnel of around 10 to 12 centimeter size. So third step is myotomy. Usually we will do myotomy around 3 centimeter below mucosal entry. So usually 5 centimeter above LES and 2 centimeter below LES, we will make a, you can see this is a complete muscle cut, myotomy. Actually we can selectively cut only circular muscle also. You can spare longitudinal muscle. So this is myotomy. And we'll cut up to this G junction, 2 centimeter below G junction also. So you can see entire this thing. So the idea is you have to preserve this mucosal flap. We are creating a third space. That is, third space is nothing but submucosal space. First space is lumen, second space is peritoneum, third space is submucosal space. So we are creating a submucosal tunnel or a space. So this mucosal flap will be preventing the connection between lumen and peritoneum or mediastinum. So if there is a breach in mucosa, there will be a chance of mediastinitis. So you have to always preserve mucosa. You can cut muscle entire length, no problem actually. And till the lower end, till the stomach, you have to up to 2 centimeter below G junction, that will be entering into stomach also. You can see this is blood vessel actually. These vessels are specific of stomach. This palisading of vessels are specifically seen in stomach, not in esophagus. So the chance of bleeding is more in stomach actually. So we are cutting till lower end. Then last step, that is closure of mucosal entry. That we are using hemoclips. It will be around 5 to 6 hemoclips we can apply, and we can close this mucosal entry so that the space is preserved. There will not be any entry of food into third space. So this is the idea. So you have to close the mucosal entry using hemoclips. So you can see nicely, you can see that 2 centimeter mucosal cut is closed with 6 hemoclips. This entire procedure will take around 90 minutes or around 100 minutes, and this will be usually done under general anesthesia. So coming to, this is a post-poem manometry. Usually we'll repeat manometry at the end of 3 months. And you can see that that IRP, which was around 22 initially, now it has come down to 4. That means very good response. So now patient is absolutely asymptomatic, patient is normally taking, and there is very good weight gain also. So this is Eckart scoring. Usually we use dysphagia, regurgitation, torsional pain and weight loss. This patient had Eckart score of around 9, and at the end of procedure, at the end of 3 months, her score was 3. That means very good response. So classically, as you know, achalasia is characterized by loss of ganglion cells at the level of LES, and there will be actually loss of inhibitory interneurons. That means loss of this nitric oxide and VAP producing ganglion cells at LES, and very less of failure of relaxation of LES. That's the classical achalasia. And if you see the pathogenesis, usually there will be genetic predisposition followed by autoimmune mechanisms along with environmental factors. Usually this is herpes simplex infection. Usually that is the cause of achalasia cardia. And the best method to prove achalasia is always high resolution manometry. This is the normal manometry, high resolution manometry. You can see this is the peristaltic wave going down, and this is LES pressure. Usually it will be less than 15 millimeter. And if you, there are 3 types of achalasia cardia. Type 1 is characterized by high, there is no peristalsis, and IRP will be very high. Type 2, there will be pan-esophageal pressurization. That means the simultaneous contraction. This is not normal contraction, but esophagus is contracting simultaneously. No peristalsis, but low amplitude contraction. Type 3 is called vigorous achalasia. That means there is some contraction, but this is not effective contraction. But high amplitude contraction, but not making a peristaltic wave. It's called type 3 achalasia. Actually, POEM is best for type 3 achalasia because you can increase the length of myotomy up to 10 to 12 centimeters. So, for type 3 achalasia, POEM is the best. For type 1 and type 2, you can try Heller's myotomy also, laparoscopic Heller's myotomy also. For type 3, POEM is the best. So, coming to treatment of achalasia cardia, you can try pharmacological treatment like nifedipine, isosorbate dinitrate, and sildenafil also. But the problem is tolerance. You cannot give these drugs more than 6 months. This will not be effective. And some people are using botulinum toxin also. This is effective for at least for 3 to 6 months. So, if patient is not fit for surgery or for POEM, you can try botulinum toxin injection. And again, previously we used to do pneumatic dilatation also. That means the idea behind all these things is you rupture the LES muscle. So, with the use of a muscle, balloon, you can rupture LES muscle. So, this is again effective, but nowadays we are not doing that much pneumatic dilatation because it's not that if you see the 1 year result, it will be around 60%. Whereas POEM and Heller's myotomy, it will be around 90%. So, we are not doing dilatation as of now. And again, classical laparoscopic Heller's myotomy. Again, usually they do anterior myotomy. So, and advantage of this laparoscopic approach is you can couple this myotomy with fundoplication, either anterior or posterior. So, it can prevent the GRD also. So, you can post-operatively that GR you can prevent with this fundoplication. But again, nowadays we are doing POEM-F also. That means along with POEM, we can also do fundoplication. That's called POEM-F, a modification of POEM procedures. So, for POEM, actually there are 4 main steps. One is mucosal entry, second one is submucosal tunneling, third one is myotomy, and fourth is closure of mucosal entry. So, these are the 4 fundamental steps of POEM. Coming to post-op care, usually we keep these patients for NPF for 1 day, and we'll do a diet study on 2nd day, and we'll start oral diet from 2nd day onwards. Antibiotics are given only for 1 day. We can discharge the patient on 3rd day, and we usually do a barium or manometry at end of 3 months. So, what are the advantages of POEM over Heller's myotomy? First and foremost, less blood loss. But again, even in laparoscopy, again, blood loss will be very minimal. But operating time, if you see, it will take around 60 to 90 minutes with the laparoscopy. So, this is actually the most advantage of POEM. That means you can tailor the myotomy. 10, 15, even up to 20 centimeter you can cut. This is not possible laparoscopic Heller's myotomy. And again, another caveat problem with POEM is, if you see, they are coupling it with fundoplication. But again, now we are coming with POEM-F, that we can also do fundoplication along with POEM. So, that part also we can take over. So, this is actually largest study from India. That's from Asian Institute of Gastroenterology. There are around 400 patients done over 5 years. And you can see the response, very good response, especially for type 1 and type 2. If you see the response for type 3, it's only around 70%, 70 to 80%. Whereas for type 1 and type 2, response is more than 90. So, POEM works better for type 1 and type 2 achalasia, but compared to laparoscopic Heller's myotomy, for type 3 also, POEM is better than laparoscopic myotomy, Heller's myotomy. And if this is the recent meta-analysis, again showed that POEM is equivalent to laparoscopic Heller's myotomy and better than pneumatic dilatation. So this is the algorithm for management of achalasia. Patient is high surgical risk. Patient not fit for surgery or POEM. You can try botulinum injection, or you can try pharmacological therapy also. Drugs you can try. But patient is low surgical risk. Then you can try with either POEM or laparoscopic Heller's myotomy. And again, there is failed POEM or failed myotomy, Heller's myotomy. You can try either POEM or you can try other dilatation also. And if patient is having sigmoid esophagus, not responding to any of these measures, you can try esophagectomy, because we are not doing esophagectomy nowadays because POEM is highly effective. So any patient you can try POEM. Thank you. So if any questions, I can. Otherwise, we'll go to our next case.
I'll be presenting a case of neuroendocrine tumor of the rectum, which was managed using endoscopic full thickness resection. So there was a 52-year-old female who presented with history of constipation since 8 years, and she underwent a colonoscopy somewhere else which showed a lesion in the rectum. She was on treatment for bronchial asthma for 10 years, after which, because of constipation, she was referred to a gastroenterologist who performed a colonoscopy and found that there was a 12 to 13 millimeter subepithelial lesion in the rectum. The lesion was biopsied, and the biopsy was suggestive of a neuroendocrine tumor. A CT was also done from there, which did not show any other focal lesions. On examination, there were no significant findings. The routine investigations were done, which were within normal limits. Chromogranin A levels were high, around 350. We also got a DOTA scan done, which showed no evidence of metastasis. So going to the video. So this is the subepithelial lesion which was seen in the mid-rectum along the posterior wall. It measured around 10 to 12 millimeters in size with normal overlying mucosa. We performed an EUS to see the extent of the lesion. The lesion was seen within the submucosa. This is the submucosa here, and this is the muscularis propria, and the lesion was just impinging on the wall. So this is the novel device which was used. This is the clip which you can see here. The clip is mounted on top at the distal end of the device. This is a grasper. This is for marking, and the other one is the deployer. So this is an illustration which shows what we have done for the patient. So this image shows that this is the subepithelial lesion which is grasped using the grasper, and it is pulled into the device, after which the clip which is loaded here has been deployed, and once the clip is deployed, the lesion is resected. So now we are marking the areas around the lesion. The device is loaded, and once we are near the lesion, the grasper comes out. We are trying to grasp the tip of the lesion so that we can try to pull it within the cap. So we apply a gentle suction as well. So the problem with this is the grasper tends to shear away the tissue, and you might actually lose the grip of the tissue. So that is what happened here. But however, with slow and steady suction, we could make sure that the entire lesion was within the device by knowing that all the markings are within the cap. So with gentle suction, the entire lesion was inside, and the clip was deployed just now, after which the resection was done. So once the lesion was resected, it was removed, and the site was reassessed. This is the clip. So you can see the perirectal fat here. All the layers of the walls of the rectum was also seen, and the lesion was mounted. Post-procedure period was uneventful. The entire procedure time was around 18 to 20 minutes. Oral feeds were resumed after 6 hours, and patient was discharged the next day afternoon. So the advantages of this Ovisco FTRD device is that it is fast, it is transluminal and minimally invasive technique. It has both diagnostic and therapeutic indications, and it also resects all the layers, including the serosa. So the advantages are, since the clip is being deployed first and the resection happens after the clip has been deployed, there's minimal thermal injury. The next important point is that this complete en bloc resection, R0 rates are close to 90 to 95%. Less than upper GI device is different from the
Good evening. I'm here to present a case of acute cholecystitis, which was managed by EUS-guided cholecystogastrostomy. The patient was an 82-year-old gentleman who presented to the emergency department with complaints of right upper quadrant abdominal pain, along with fever and chills of 2 days duration. He was a known diabetic, hypertensive, and he had coronary artery disease, status post PTCA with severe LV systolic dysfunction. At initial presentation, he had tachycardia, hypotension, and Murphy sign was positive. Evaluation was consistent with a calculus cholecystitis, acute kidney injury with sepsis, without any evidence of choledocholithiasis or extrahepatic biliary obstruction. He had a significant similar illness twice within the hypotension was responsive to fluids and vasopressors. Gradually, the vasopressors were tapered off, acute kidney injury resolved. However, he had persistent neutrophilic leukocytosis and elevated CRP. Now, in view of recurrent acute cholecystitis and very high surgical risk, even though the definitive management would be a surgical cholecystectomy, he was deemed to be a high risk case, and the patient family was not willing to accept the risk associated with the cholecystectomy. Now, the options remained with the percutaneous cholecystostomy or percutaneous transhepatic gallbladder drainage or an endoscopic approach. Now, of late, endoscopic approach is being widely used, and it has been standardized than in earlier times. There are two main options. One is endoscopic transpapillary gallbladder drainage, and the other is endoscopic ultrasound guided gallbladder drainage. The second one goes through the wall of the gut. Now, percutaneous transhepatic gallbladder drainage involves, as we know, is time tested, and it is the go-to method for percutaneous cholecystostomy. Is the rescue method that we go for in cases where patients are too sick to undergo an immediate cholecystectomy. We can buy time. Once the cholecystectomy settles, the patient can be taken up for surgical intervention. Now, problem happens when a patient is too unfit even after the resolution of the cholecystectomy. In such cases, percutaneous transhepatic gallbladder drainage, the catheter might not be able to be removed unless the patient is fit enough to undergo a cholecystectomy. EUS guided gallbladder drainage offers a rescue in such cases, where a patient, if the patient is not deemed to be a surgical candidate for the rest of his life, for example, in a very elderly patient with too many comorbid conditions, and you do not expect him to become a surgically fit candidate for a laparoscopic cholecystectomy, he has a percutaneous drain in situ. Now, you can use an internal drainage so that the percutaneous drain can be removed. So, in cases where there is no GB perforation and the patient is able to tolerate sedation, that is, anesthesia can be provided, percutaneous gallbladder drainage is a viable option. And if the patient is unable to undergo sedation and there is GB perforation suspected, then the only go-to option would be a percutaneous transhepatic gallbladder drainage. In cases where there is no perforation and there is the patient has uncontrolled ascites or severe coagulopathy, or the patient requires an ERCP, then the initial approach favored would be a transpapillary, because the patient anyway has to undergo an ERCP for clearance of the gallbladder of the CBD, say for example there is a stone in the common bile duct, or there is a tumor blocking the common bile duct, the patient has to undergo an ERCP for decompression of the biliary tract. In such cases, we can cannulate the cystic duct and put in a stent into the gallbladder so that a temporary drainage of the gallbladder is obtained, and once the cholecystectomy settles, we can either undergo cholecystitis settles, he can either undergo cholecystectomy or he can be planned for repeat stenting of the gallbladder. While in cases where the patient can undergo sedation, we can and if ERCP is not possible, say in cases where there a gallbladder drainage through EUS. So in cases where there is gallbladder perforation or biliary peritonitis or large volume ascites or significant coagulopathy, EUS gallbladder drainage may not be feasible, and a patient who is intolerant to anesthesia also, gallbladder drainage may not be feasible. Now the prerequisite would be that we should plan ahead. For example, in a patient who is a candidate for future surgeries, the surgeon has to be consulted prior to the procedure, because we are putting in a stent which would remain there, and if the patient has to undergo cholecystectomy, at the time of cholecystectomy a fistula repair of the gastric or the duodenal wall will be required. Now there are two major ways of doing a gallbladder drainage. One would be using a hot stent, that is a metallic stent, lumen opposing metallic stent with integrated cautery, or another would be without integrated cautery. Now with the introduction of the hot axios integrated system, we have the advantage that we can avoid the use of fluoroscopy, and the stent and the cautery comes in one system. Once we have the gallbladder close to the gastric lumen or the duodenal lumen, that is the distance between the lumen and the gallbladder wall is less than 10 millimeter, the hot axios system can be used to directly puncture through the wall and enter the gallbladder lumen. The distal flange is first deployed within the gallbladder lumen. It is pulled back, and once it is snugly fit, the proximal end is deployed within the scope, and the proximal end is opens up into the gastric or the duodenal lumen. We usually put in two double pigtail stents, so that one major disadvantage with the hot lumen opposing stent is that food can go from the lumen into the gallbladder. So we put in usually two double pigtail stents so that food entering into the gallbladder is the risk is reduced, as well as the bleeding risk and migration risk are also reduced. Now coming to our case, as we can see here, this is the gallbladder, which is close to the gastric lumen. We have already deployed the first flange, and the second flange, or the luminal portion of the flange of the stent, is being deployed at this moment. And we can see, we are switching over to the endoscopic view. We can see that the gastric side of the lumen opposing stent gets deployed here. In this particular case, we could oppose the gallbladder to the lumen best at the antrum of the stomach. So we went for a cholecystogastrostomy. We can see here the white bile which is draining along with copious amounts of pus. This is the pyloric channel here. The advantage of gallbladder drainage within hot axial system is that we can, on follow-up, we can do a cholecystoscopy and and clear stones which are there within the gallbladder. In a sick patient, initially just drainage is enough. We put in 2 stents, and once the drainage happens, we call back the patient after 4 to 6 weeks, and we can use an upper GI endoscope, dilate the stent if required with a balloon, and go in with the standard upper GI endoscope into the gallbladder lumen and clear any stones which are there within the lumen. Here presenter viewpoint.
battery there. പോരെ നമുക്ക് അടുത്ത സൈഡിലോട്ട് പോവാം. ഓഫായി പോവും. അതെയാ അടുത്തേക്ക് പോവാം. അടുത്തേക്ക് പോവാം.
Sorry for that. I was unable to forward the video. I'll conclude. So in this patient, after 6 weeks, we called him back. He did excellently after the procedure. His cholecystitis settled. We were able to discharge him within a week. And on follow-up after 6 weeks, we called him back, and we were able to go inside the gallbladder using an upper GI endoscopy. The gallbladder was clean. We did not require to do much of toileting, and we left one single double pigtail stent within, and he's doing well on. It's been almost 4 months since we did the procedure. We have kept the stent in situ. He's doing well, and the main advantage is that the morbidity which is associated with the percutaneous drain, which because the patient was not willing for a percutaneous drain, that is why we chose to do an US guided procedure in this patient. and the patient was very happy and he is doing well on follow-up. Thank you.
Good evening. The next presentation is regarding acute necrotizing pancreatitis with walled off necrosis, which was managed by US-guided necrosectomy. So here we have a 62-year-old male, a known case of diabetes mellitus, hypertension as comorbidities. He initially presented his the first episode of upper abdomen pain and vomiting of 1 day duration. General examination showed tachycardia with a BP of 140/90, and abdomen was tendinous. There was epigastric pain and tendinous was there. Other systems were normal. We did a USG abdomen which showed edematous bulky pancreas with mild ascites and multiple GB calculi. CBD was normal. And patient was managed conservatively with analgesics, PP and IV hydrations, and subsequently was discharged with low fat diet. So after 2 weeks, the patient presented with to the emergency department with severe fever, with chills, rigor, and altered sensorium. On evaluation, patient was drowsy, febrile with a tachycardia 110 per minute, BP was 90/60, hypertension, and respiratory rate of 24. Here you can see the blood counts were initially around 12,000. LFT was normal, so we are not suspecting any biliary pancreatitis here, and CRP was 45. So slight infection was there. Now after 2 weeks, we are looking into possibility of a complication of necrotizing pancreatitis, possibility of infected necrosis. So CECT abdomen was done, and it showed large necrotic collection replacing most of the body and tail of the pancreas with a caudal extension along the route of mesentery, suggestive of walled off necrosis with moderate ascites. Here you can see this is a necrotic collection posterior to the stomach, and it's very huge, and only the preserved viable pancreatic tissue is this part. So this is a very large collection. This is just posterior to the stomach, and blood cultures were sent during this phase. Initially, patient was managed with IV antibiotics. Patient was not responding, was severely sick with a severe inflammatory response syndrome, and subsequently, in view of it was a collaborative decision to go ahead with US-guided cystogastrostomy, because at this moment, patients the week, that is around 3 weeks following the first abdominal pain, that is the first episode. So the classical teaching is that you have to wait for 4 weeks for a well-formed mature wall in order to do a cystogastrostomy. But in rare conditions where patient is not responding to IV antibiotics, we can go ahead, considering the patient's situation, and go ahead with a cystogastrostomy. So we went ahead with a US-guided cystogastrostomy. So the first video will be showing you regarding the deployment of the stent. Here we again have used the hot axios system. Dr. Javed has recently mentioned about the hot axios stent delivery. So you can clearly see the flanks of the initial flanks, proximal flanks of the stent being deployed, and subsequently the rest of the procedure is same to the procedure he has already mentioned. And this is the endoscopic view post delivery of the stent. Now this is in the second or third day where we decided to go ahead with the necrosectomy. That is, we usually don't do necrosectomy on the same day. We wait for two or 3 days, then we go ahead with the necrosectomy. So initially we have to dilate the stent diameter in order for the endoscope to pass through smoothly. Usually we used to put 150 millimeter diameter stent, which is fairly enough, but because of the resistance around the wall, it may not dilate that much. Post dilatation, we go ahead with a forward beam endoscopy, and we can clearly make out these are the pancreatic tissue. So all this white debris is basically the necrosed portion. So classically, what we do is using a snare, we peel off all these white debris. Once you peel off the necrotic part, the bleeding will start to appear. So multiple sessions were done for this patient, around 3 sessions, and post necrosectomy, patient recovered very well. So hot axis system, already we have clearly mentioned how the hot axis system is done. So these are the components of hot axis system. You have the stent delivery system along with the stent. The basic difference happens in the stent diameter and the stent size. So the classical diameter that is available is 10 mm and 15 mm diameter, which is fairly useful, and hot axios, which comes with incorporated cautery system, makes the procedure little bit easier, very much easier. So a little bit discussion regarding how we can approach necrotizing pancreatitis. This is based on the American Gastroenterology Association guideline. So there are 2 ways the pancreatitis will progress. One is the interstitial edematous pancreatitis, that's a mild one. The other one is necrotizing pancreatitis. So less than 4 weeks, what happens is acute or pancreatic fluid collection should be having. Only fluid collection like ascites will be there. More than 4 weeks, it will convert into either pancreatic pseudocyst in case of interstitial pancreatitis, or it will convert to walled off necrosis with solid debris. Now this walled off necrosis can become a source of infection. Even pancreatic pseudocyst can also have infection. So will you treat with antibiotic therapy? Only culture proven conditions antibiotic therapy is recommended, but patient is having fever like this patient after 2 weeks, not responding for conservative management, you can go ahead with antibiotic therapy. Then if another important thing is whether to go ahead with percutaneous aspiration and go for a culture, that can be done, but in case it is not a case of infected necrosis, you are basically introducing an infection. So that is something which we usually do not recommend. Then about oral nutrition, usually in pancreatitis, the dictum is start early nutrition, early oral enteral feeding. Okay, we are against keeping the patient nil per oral, giving IV fluid for a long duration. The initial high volume hydration is effective only in the first 24 hours. Recent studies have shown that aggressive fluid therapy is detrimental for the patient. Now, if the oral feeding is not possible, then you can go for nasojejunal or nasogastric feeding. Now, when will you do these interventions? See, in this flowchart, you can see the patient is having walled off pancreatic necrosis. Now, one thing after taking CT you have to see is whether there is enough central component of sufficient size. And like this patient, I have shown the CT. CT has shown a large collection which is posterior to the stomach. That means you can easily go through the stomach and assess the give an AC assist with the cyst collection. So if this collection is transmurally we can drain, then go for EOS guided placement of lamps for drainage. If it is a no, then you have to involve the interventional radiologist. They will go for a aggressive percutaneous drainage. Now, which is better, going for aggressive percutaneous drainage or EOS guided lamps? The current dictum again is you have to go for step-up therapy, step-up approach. The step-up approach means first endoscopy, then percutaneous drainage, then go for what? Video assisted retroperitoneal debridement. Finally, open necrosectomy. Okay. So in severe acute pancreatitis with necrosis, initial phase, that is the acute phase, up to 2 weeks or 2 to 4 weeks, managed conservatively. Okay. In the late phase, more than 2 to 4 weeks, this is a confusing position where you have to make a decision according to the patient. In this patient, we have made a decision to go ahead with percutaneous necrosectomy. This cholecystogastrectomy, EOS guided. But more than 4 weeks, there is no confusion. You can go ahead with cystogastrectomy. Thank you.
All the presentations were excellent and very informative. Anybody from Pariyaram going to present? No. So, any doubts we can clear? Jimmy?
First of all, hearty congratulations to all the Gastro team from MIMS for doing the excellent work. And I am telling something about my surgeon's perspective about all these procedures. One thing I would like to tell is 2 procedures out of these 4 is definitely going to stay. One will be that neuroendocrine tumor, which is less than 2 centimeter size, which can be removed by an endoscopic total resection. And second one will be that necrosectomy. So these 2 procedures definitely is going to stay, because that definitely is having some advantage over conventional laparoscopic or minimally invasive, whatever open surgical procedures. But other 2 procedures, I have some difference of opinions. One is POEM, because whatever procedure means POEM is compared against the gold standard surgery, that is Heller's cardiomyotomy. Am I correct? Okay, the results are compared with the gold standard procedure, that is a Heller's cardiomyotomy. So in some cases the POEM will be better, means you have to select the patients. Since you have a hammer with you, don't label all the patients as your nail. Because once you have a hammer, sometimes you think that all the achalasia cardia may be your nail and you can put POEM. No, I don't think so. Because at least some amount of patients will be definitely for Heller's cardiomyotomy, because we have the advantage of doing a fundoplication along with that patient. And whatever mucosal injury, even if it happens, it can be tackled at the same point of time. And the second one is this endoscopic cholecystostomy. The problem is, I think you are doing it with general anesthesia only, okay, GA. So the same amount of time, usually it will be around 1 hour to 1.5 hours, maximum 2 hours for any acute cholecystitis or any laparoscopic cholecystectomy. The time taken will be almost same if you are going for a laparoscopic cholecystectomy. Okay, means definitely sir can answer on that. And the second thing is high risk patients, you are going for a gallbladder anastomosis. And by any chance, if the patient completely improves, I just missed that part, I just gone to the toilet. And if by any chance, you are mentioned that, I think so, if by any chance if the patient improves and this patient requires a laparoscopic cholecystectomy, that going to be a hell lot of a difficult for us, because we have to close the enterotomy or duodenostomy or gastrostomy which you are created, and along with that stent in situ, that metallic stent in situ is going to be a big problem for us. That is one point. Means you will have an answer for that, but definitely. And I think we have covered all 4 cases, no? Okay.
So regarding the advantage of POEM or Heller's, actually there is not much advantage except for type 3 achalasia. For type 3, because we can make the cut at up to 15 centimeter also. 15 or even 20, we can start from POEM is the best. For type 1 and type 2, for Heller's you can combine it with fundoplication, either anterior or posterior. But that's what I'm telling. This endoscopy is improving day by day. So we can combine this with fundoplication also. If you do anterior myotomy, you can combine with fundoplication. Takes around 30 minutes more, that's all. We can enter into peritoneum, same thing, we can we can do anterior this door fundoplication like that, we can do a tight wrap also, almost like door. So results are almost same. So that part you can, this endoscopy is improving drastically. The results are almost the same. So again, patients you can give the choice to patient. So they can decide. Because the results are almost the same. Same as like in either Hellers or poem. Same results. And if you see the real GRD post poem, actually it's very less. If you do high resolution manometer, 24 pH symmetry, the incidence of GRD, it's only around 12%. With laparoscopic enlargement, it's around 6%. The difference is only 6%. So the real incidence of GRD is very less. With either poem or with myotomy, enlarged myotomy, real incidence is very less. If you do with the pH symmetry, the incidence is very less. So we can tackle it with the poem of course.
Definitely, I have the advantage of witnessing this poem in our OT itself, and the way they are doing dissection and between the submucous and the muscular layer and the glassy tissues.
Yeah, the submucous layer.
Yeah, submucous and glassy tissues, they are using hot layers. Awesome. I just said there is a big hats off to them. The dissection we are doing with a small endoscope is really fantastic.
Yeah, we can.
That's, I appreciate that. You can combine with it, definitely fundoplication. Definitely, you are the boss.
But again, choices we can give to the patient. They can decide. The results are almost same, so the decision will be with the patient. You have to tell openly that results are almost same. You can choose. So patients are getting more choices. So that actually that fundamental idea of medicine is like you have to offer more choices to the patient. It's not that we are great. So we will give the patient can definitely decide. So we are creating more and more choices. That's the idea.
More correction. We can do the 15 centimeter myotomy also. We are doing mediastinal.
Yeah, we are doing